Good afternoon. Thank you everyone for being here. I'm Rachel Greenup. I'm the Chief of Breast Surgery in the Department of Surgery here at Yale School of Medicine and co-director of the breast program here at Smilo. And it's my honor to introduce my friend and colleague, Dr. Siba Haykal, who's Section Chief of Reconstructive Oncology in the Division of Plastic and Reconstructive Surgery. Dr. Haykal is a specialist in microsurgical reconstruction with research interests in breast reconstructive surgery and vascularized composite allotransplantation. She received her medical degree from the University of Ottawa, completed residency training in plastic and reconstructive surgery at the University of Toronto, did a microsurgery fellowship at the Albany Medical Center in New York, and during her residency completed a PhD in tissue engineering and regenerative medicine. She worked at Toronto General Hospital, University Health Network, and Sinai Health in Toronto for several years prior to being recruited to Yale as an associate professor. She has received many awards for her leadership, including the American Society for Reconstructive Microsurgery, Women in Microsurgery Travel Scholarship, and the Hugh G. Thompson Humanitarian Award. She's the author of over 50 peer-reviewed publications focused on her research niche of breast reconstruction, cancer reconstruction, microsurgery, tissue engineering, and tissue repair. And I can say on a personal note, having both sat on the search committee as part of her recruitment and now having gotten to know her both as a clinician and a colleague, she is excellent in everything she does, and we are so lucky to have her here at Yale. Welcome.
Thank you so much, Rachel, and thank you for having me today. It's an honor to be giving grand rounds today. So we'll be discussing a novel surgical management of cancer-related lymphedema, and specifically I'll be talking about a few projects that we're working on currently and we've worked on at my previous institution. So the objectives are to determine which patients are candidates for surgical management of lymphedema, to look at options for surgical and microsurgical management, to look at preoperative and postoperative rehabilitation protocol, to discuss future techniques such as prevention and in vivo models, to look at some of the qualitative studies, and to look at prediction models, specifically looking at some of the data here from the Smilo Cancer Center. My disclosure is that I am a consultant for Stryker. So acute lymphedema really presents with generalized protein and fluid accumulation, which leads to inflammation and dilation and fibrosis of the lymphatics. And chronic lymphedema is a sustained inflammatory response, increase in excessive adipose tissue, fibrosis, dilated vessels, and lymphangiogenesis. And there is a theory that we can potentially prevent chronic lymphedema if we can halt acute lymphedema. Obviously, the management of lymphedema is a multidisciplinary approach. So it starts at the time of cancer diagnosis and it runs through all the years of life. It really should focus on prevention and surveillance. So early assessment, referral for exercise and rehabilitative therapies, early physiotherapy is key, and really the treatment centers around that. Why is this necessary? We know that it reduces economic burden associated with intensive rehabilitation and hospitalization for infection. And secondary, education, which is promotion of positive self-efficacy strategies, really reinforces the survival's ability to control lymphedema through early detection and early referral. So really the mainstay treatment is called combined or complex decongestive therapy. So it involves two of multiple modalities, the first one being manual lymphatic drainage. So there are several different techniques. The Vater technique, the Foldy method, the Leduc method. There's a plethora of articles that have been published on the effectiveness of these techniques, but there's really not a lot of data that really compares these methods, and we know it really depends on the training of the therapist. And also compression. So compression allows to reduce that venous pressure and flow, which reduces the lymphatic load and encourages the lymphatics to take on that tissue pressure. So that basically looks like bandages and then garments in later stages. So there are two phases to combined decongestive therapy. The first one is to reduce the size of the limb and to improve the skin. The second phase is ongoing, it's individualized, it's about self-management to maintain all the gains from phase one, and it's using those low stretch elastic stockings and sleeve compression and multi-layer stockings. So the goals are to reduce the swelling, increase the drainage, reduce the skin fibrosis, enhance the patient's functional status, relieve discomfort and improve quality of life, and really also reduce the risk of cellulitis. So staging in lymphedema is actually key, and this really centers on whether or not these patients are candidates for surgery, which I'll further discuss. But there are several different staging systems. The one that we typically use is the one that was created in 2013 by the International Society of Lymphology, which divides into stage 0, 1, 2, and 3. So stage 0 is subclinical. It's the absence of edema. So these are patients who will not actually see any volume changes, and whoever's examining them, whether it's their physician or even their surgeons, they won't actually see any changes in volumes. However, we know that those patients potentially have risk factors for developing lymphedema. And ideally, as a surgeon who works with patients who have lymphedema, I would love to see them when they're at a stage 0. So we have to be able to identify these patients early on. In terms of stage 1 and stage 2, there's different modalities for looking at how we determine whether or not there are these stages. So one is being physical examination, looking for pitting edema. So if you speak to therapists, pitting edema is good. It's something that we can work with. It allows us to put compression on. It allows us to use elastic bandages. It allows us to actually allow for the flow. And however, when there's no longer pitting edema, we start thinking that there's now progression of the lymphedema, and therefore we have to think about other modalities. So typically for patients in stages 1 and 2, we reserve physiologic techniques. So those are the microsurgical, super microsurgery techniques that I'll talk about. And at a later stage, the possible surgical techniques are things like liposuction and ablative techniques. So these are examples of what a patient could look like at the different stages. And we also start seeing skin changes that are going to range from mild skin changes that could be reversible to moderate skin changes that are potentially start becoming irreversible with some hardening of tissue, some dry skin, some discoloration, where elevation is no longer helpful. And when we get to the severe stage of elephantiasis, it's extensive hardening, and very, very few things are actually helpful at that stage. Now, what happens when we look at the lymphatic vessels under the microscope at different stages? So typically, a normal lymphatic vessel is thin, is translucent, and we can see flow when we cut into it. There's actually flow that comes out. The flow is slow, but it is there. Eventually, with later stages, for example, as a stage 1, we see what we call ectasia, followed by contraction and then sclerosis. So at that point, the vessels actually look very different under the microscope. When you cut into them, there's very little flow, and they're no longer potentially available for things such as a bypass. Now, how do we determine what the most appropriate surgical technique is? It really depends on the things that we just talked about. So staging is key and imaging is key. The first thing that we want to know is, does the lymphatic system still work? Are there still any lymphatic vessels available? Most likely in the distal portion of the limb that are still flowing. So we do clinical examination. We look at the different stages that we talked about, whether or not there's actually any edema. And another modality is lymphoscintigraphy, where a radioisotope is injected in the web spaces of the hand or the feet. And we look at whether or not there's actually any flow. And as you can see here, I'm not sure if you can see my cursor, At stage 0, you'll still see some flow going into the inguinal area. Here, there's some flow that is starting. Eventually, there's what we call dermal backflow, which I'll describe a little bit more, but we can still see that there's some flow in the inguinal area. Stage 2, which is further progression, there's very little that is lighting up in the inguinal area. And in this case, this is the other limb at stage 3 where there's no flow and complete obstruction. So another modality that we use that is a very helpful modality that I feel is one of the things that most commonly we use and is very helpful at figuring out whether or not the lymphatic system works is indocyanine green. So that's a fluorescent dye that is injected in the same area. This can also be done in the clinic. And we've also been able to map out the progression of lymphedema depending on what the imaging looks like. So what we do is we use a near-infrared spectroscopy. It's called the SPY machine to take a look at the limb and to look at whether or not there's linear flow, which is normal flow. Then we start seeing different patterns. We start seeing a splash pattern, a stardust pattern, and a diffuse pattern as there's progression of lymphedema. So the interesting thing about doing this is that you can actually see it in real time. You can start seeing the flow, the movement of the lymphatics within the channels. And you can also map that out, but also record it. So this is an example of one of my patients that I injected in the operating room, where you can see there's flow up to the level of the elbow. However, the flow changes. Initially, there's some linear flow, followed by a splash pattern, a stardust pattern, and eventually a diffuse pattern with no further progression above the elbow. So that allows us to figure out if, for example, this patient, we did lymphovenous bypasses on. I'll talk about it a little bit more in detail. But this intraoperative ICG lymphangiography is key because I know in this area where there's a linear pattern and there's some flow, this is where I'm going to do my bypasses. Because if I travel more proximally up the limb, then there won't be any lymphatics that are flowing, and I won't be able to bypass them. This is an example under the microscope of a lymphatic that is stained in blue that is being anastomosed to a small venule that is of equal size. These vessels are typically less than 1 millimeter in size. In this case, this vessel is about 0.7 millimeters. So for a lymphovenous bypass, we would typically perform multiple different bypasses along the arm in the area where we'd expect lymphatic flow or lymphatic vessels to still be present. So what is a lymphaticovenous bypass, also referred to as an LVA or an LVB? So it's a microsurgical anastomosis of a lymphatic vessel to a small superficial vein to shunt that lymph fluid into the venous system. So the theory is that this lymphaticovenous anastomosis will remain patent and open if the lymphatic pressure is higher than the venous system. So you can imagine if you open one of the venules and there's a lot of flow coming out of it, that is not a good recipient vein, right? So you have to really find the appropriate venule to do that. So that is best ensured by looking for a low pressure subdermal venule. And we think from looking at the studies is that patients could have a mean reduction of about 35% of their volume at 1 year. And we also know from looking at studies that have been going on for quite some time is that after about 2 to 3 years, these patients potentially need more lymphovenous bypasses. What's a lymph node transfer? So it's LNT or vascularized lymph node transfer. So this is typically reserved for stages 2 or more. So basically the recipient bed where there's a lymphedema is first prepared. So one of the most important things in that area is to excise all the scar because we think that removing the scar will actually help with the flow. And then you take a flap basically of tissue that has some lymph nodes in it. So the lymph nodes can be obtained from different sites, the omentum, the inguinal area, the thoracic area, or the cervical area. And ideally you want to take them from areas where patients will not be developing lymphedema. So reverse source mapping is key to determine which areas to take them from. So the theory behind this is that you're transferring healthy lymph nodes. They're going to actually produce vascular endothelial growth factors that's going to promote lymphangiogenesis and new connections between proximal and distal lymphatics. The removal of the scar itself is also going to enhance the immunological function and reduce the development of infection. But there's no data that actually suggests that lymphatic vessels actually regenerate from those nodes. So all those nodes, the only thing they're doing is producing the growth factors required to allow the lymphatic vessels that are there to actually reform. So preventative techniques are also important. So one preventative technique used to be called the lymphatic microsurgical preventing healing approach, LYMPHA. We now call it immediate lymphatic reconstruction. So this is used for primary prevention of arm lymphedema, for example, in breast cancer, but it can also be used for melanoma in the trunk. It's a lymphovenous bypass, similar to what we just described, but they're done in a patient who does not have lymphedema. So they're done as a possibly preventative method to hopefully decrease the risk of lymphedema. And they don't require any lymph nodes. They don't require any lymph vessel harvesting. So our algorithm for treatment is in the phase 1, when I see a patient that has lymphedema, I want to make sure they're well optimized for their CPT or their CDT. So they have therapists on board, they've done their combined decongestive therapy, they've been very rigorous for 6 to 12 months. You'll see that most of the patients that we do end up seeing, and we'll talk about barriers of care in this area as well, are patients who are actually very good at their lymphedema care. And then the second phase would be microsurgery. And then the post-operative phase is just as important, which involves a lot of rehabilitation and a lot of follow-up. So in terms of what do we do? So for prevention, we try to avoid lymphatic injury as best as possible by performing good dissections. And we try to do immediate lymphatic reconstruction. And for treatment, early on, at an early stage, we would do multiple lymphovenous bypasses, and later on, maybe liposuction, once we're at a stage where there's more of a fatty component to the lymphedema, which happens in the chronic lymphedema phase. The post-operative protocols are very key. At my previous institution, we had a very big group involving physiotherapists, manual lymphatic therapists, and we came up with different ways to follow them post-operatively. It really depends on whether or not they're having a lymphovenous bypass or a lymph node transplant. It involves 6 weeks of compression. It involves a change in the manual lymphatic regimen. So we talked about a low flow to low flow system, where typically patients who have lymphedema massage up towards the axilla, for example. In this case, you want to keep the anastomosis open, so you actually start massaging towards the anastomosis as well. And the goal is for them to decrease the amount of compression and time they actually spend on their lymphedema care. We also, we started a prospective study, so we wanted to see, do these things actually work? Does surgery actually work? So we teamed up with Dr. Fifi Liu and her lab at Princess Margaret Hospital at my previous institution, where we operated on patients who had lymphedema, and we followed them with time. Interestingly, they were really interested in looking at potentially any biomarkers or any transcriptome profiling for patients with lymphedema. We looked at PPARs, which are peroxisome proliferator activated receptors. We found, interestingly, that the dermal fibrosis staining in lymphedema is increased. We also looked at RNA sequencing, and we looked at heat maps to look at what is downregulated, and we noticed that these PPARs were actually downregulated in patients with lymphedema. So these are from biopsies from their skin. And more importantly, we looked at IL-17 signaling using immunohistochemistry, and we found that there was an upregulation of IL-17. So what does this mean? So these PPARs are fatty acid sensors. They're involved in transcription. They're involved in adipogenesis, lipid metabolism, insulin sensitivity, and maintenance of metabolic homeostasis. Their reduced expression really suggests that there's a metabolic shift that could contribute to this inflammatory stage. And the RNA sequencing of these tissues really demonstrated that there's a downregulation of these and including different targets. So really this highlights the role of particular genes in this, most specifically PPAR gamma and other related FAO genes. They were really interested in looking at, can we have target therapeutics for patients who currently have lymphedema? So we know from these observations that lymphedema is linked to obesity, but also metabolic syndrome. And the goal from this was to really investigate these metabolic alterations at the time of cancer surgery. Our goal is to identify the early markers of lymphedema risk, to evaluate baseline inflammatory markers and cytokines in patients who are undergoing lymph node dissection, to understand the roles of PPAR gamma and FAO pathways. It could really help in predicting a framework for assessing lymphedema risk, and to really bridge the gap between inflammatory states and later metabolic dysfunction in these patients. And ultimately, the goal is to identify a biomarker that predicts who will develop lymphedema. So with these patients as well, we did a prospective study looking at the impact of lymphovenous bypass and lymphovenous anastomosis as a treatment for upper and lower limb lymphedema. And Catherine Bowman, who's currently doing her PhD at Stanford, worked on this with our cohort, our patients from Toronto. She is going back to do her medical school in Calgary after she's done her PhD, but this was one of her the studies that she worked on. So I want to first thank all the members involved in this study. We had a lot of patient advisors for the study who had invaluable contributions. We did a lot of interviews with these patients, and we had a lot of study participants. So we wanted to look at whether or not prospectively are we decreasing volume, but more importantly, can we look at quality of life for these patients? So what we used is we had an initial consult with our patients with lymphedema. They had a clinical appointment. We used ICG Green to map them in the clinic. We identified them as possible candidate for lymphovenous bypass surgery. They had already been doing CDT, but they underwent a 2-week bandaging regimen, which is a 3-layer compression. They then underwent a preoperative assessment of limb measures, questionnaires, interviews. They underwent their lymphovenous anastomosis intraoperatively and then underwent 6 weeks of bandaging regimen after, and we followed them postoperatively where we performed limb measurements again, questionnaires, interviews, and I want to show some of the results from this. So the primary outcome that we looked at was limb volume change based upon circumferential measurements. And we did find that there was a significant decrease in their volume measurements. But what was important for us was to look at the secondary qualitative outcomes. So we performed semi-structured interviews that really focused on quality of life, psychosocial well-being, symptomology, function, and surgical experience. So these are our results. So our findings in terms of demographics are most reflective of the published literature. So the majority of patients were female. They had stage 2 lymphedema and a history of cancer. And when we looked at some scores, some quality of life scores that were not for lymphedema in particular, there was no significant increase or decrease. There was just no significance. But when we looked at quality of life scores, so lymph quality of life score, we noticed that preoperatively compared to postoperatively, there was an increase in their quality of life score. So let's look at some of the preoperative qualitative findings. So in terms of functional impacts of lymphedema on their activities of daily living, their mobility, and their activity limits, 93% of these patients had an impact on their activities of daily living. 87% of them had limited activity. 79% it impacted their mobility, and 73% it impacted on exercise. So a patient said, I cannot lift things. It would have been easy to lift them before, There are times where I need actual help to get dressed. There are just things that I can't do anymore. In terms of physical symptoms, 91% reported swelling and 60% reported pain. We often don't consider pain as something associated with lymphedema, but it can be. The pain is debilitating, and the pain causes me stress, which is very hard on my mental health. In terms of psychosocial impacts, so on anxiety, low mood, and chronic disease coping, 77% of patients had an impact on low mood. 55% talked about anxiety, 18% had anxiety with their upcoming surgery, 36% had anxiety related to their disease progression. I'm strong-minded, so when I talk to somebody one-on-one like this, I get emotional. But in front of my family, I put on a very, very brave face and I try to push it through, or I can pretend that I'm okay so they don't worry. In terms of cellulitis, 41% of our patients experienced cellulitis with more than one episode. They reported fear and distress related to cellulitis, and 24% of them were hospitalized. I'm always concerned that the antibiotics will stop working, that I'll have a raging, uncontrolled infection, and there's also a potential for death. In terms of treatment modalities, these patients have pretty much tried it all. Obviously, compression and manual lymphatic drainage, exercise, pneumatic pump, skincare, there's always some sort of new device. And there's a lot of treatment challenges related to discomfort, improper fitting, financially, as well as mobility restriction. I hate compression garments. I don't think anyone likes wearing them. It's like wearing a scuba suit. It's difficult to walk. I get shortness of breath walking up a hill because there's like this added resistance. Now let's look at our post-operative qualitative findings. In terms of limb volume, discomfort, pain, heaviness, tightness, and tingling, 88% of patients reported reduction in heaviness. So heaviness is one of these things that I feel we don't ask about enough. It's the patients that come with stage 0 disease, and we do different measurements and we don't see a difference at all, but really they're feeling heavy. So those are the patients we need to see early. 83% of them reported pain reduction, 78% of them reported volume reduction, and 67% reported reduction in discomfort. It's been almost 2 years since I've had the surgery, and I was dealing with constant pain and swelling. And after the surgery, I've noticed a huge improvement. In terms of functional impacts of LVA, I'm moving heavier things. I'm lifting heavier loads. So it could be anything from groceries to furniture. I'm participating more in moving those types of things and I wouldn't before. More rigorous cleaning, some more sustained activity where usually I would take more time to rest. In terms of appearance, anxiety, depression, fears, and worries, 75% had a positive change in appearance, 50% of them had a fear that lymphedema would return, and 50% had mood improvement. I can see my wrist bone, and I could never see it before. I might be able to get my wedding ring on soon, so that's pretty impressive. So the postoperative bandage regimen, it's not a mystery that they were not happy with it. So the only time I remove the bandaging is in the middle of the night. I try to change it at 2 o'clock. It starts bugging my feet. My feet start feeling weird, like pain, and I feel needles, and then I feel numb, and then I have to remove the bandages. So there continues to be challenges. What were their reasons for seeking out surgery? 80% of them were looking for symptom control. 40% had exhausted all other therapies, and 30% had a physiotherapy referral. It felt out of control. I went to lots and lots of appointments with therapists, and we weren't able to contain it. I was so worried that I would swell, and one day I'd have an infection and I would lose my arm. I was so worried about it. I already lost body parts. I just need a break. I just want to focus on normal things like normal people. The meaning of surgery. They expressed things like gratitude, hope, and symptom control. 70% had symptom and situational improvement. 60% felt hope. 40% felt gratitude. Tears are coming to my eyes. It's hard to put into words. My best attempt is a fresh start, hopefulness, and care. I really feel cared for and so grateful for the help with this. Yes, it's surprising me too how different I feel now after having surgery. I always felt like there's a point, I'm devoting so much time to this, but I can actually now see the results of my management clearly, and I'm more motivated in doing this. I do feel like it's made a difference in terms of stopping the progression at the speed at which the disease progresses. I feel like I've gained some time. I'm not as worried about things going badly in 5 years. I'm now thinking, okay, maybe this is a relatively good quality of life for the next 10 to 20 years in terms of my leg alone. I'm not as worried about it. I feel relief. So in terms of synthesizing this data, we've come up with models of care. The fundamentals of surgical lymphedema care will center on patient screening and eligibility, comprehensive perioperative education, post-operative functional rehabilitation, psychosocial support for anxieties, fears, and worries that they all express, and outcomes assessment, really looking at timelines, frequency, and tools for these outcomes. So a second project that I want to talk about is one that Alex Matia has taken the lead on. She's a medical student in Florida working with us for a year as a research fellow, looking at disparities in breast cancer-related lymphedema. We did a systematic review of inequities and barriers in care. So we know that this is a chronic condition. We know that patients of diverse and disadvantaged patient populations continue to be understudied in the area of breast cancer survivorship. So we wanted to summarize the evidence for disparities and barriers surrounding breast cancer-related lymphedema care, particularly in diagnosis, in education, and accessibility to treatment. So we followed the PRISMA guidelines. We did a search of multiple different web bases. We followed the Joanna Briggs Institute critical appraisal tool. We included different types of studies and multiple articles. We yielded 1059 articles, 39 of them met the inclusion criteria. We looked particularly at racial and ethnic disparities, increased risks with certain demographic factors. We looked at inadequate provider and patient knowledge. We looked at low patient education and burden. We looked at barrier in receipt of healthcare provider diagnosis. And the sub-themes that we looked at are cost burden, psychosocial barriers, and the role of patient self-efficacy. So this is what we found. So younger, non-Caucasian patients located in rural geographic regions with low income and education levels appear to be at greatest risk for self-reported breast cancer-related lymphedema rather than physician-diagnosed. The patients of diverse racial and ethnic backgrounds and low socioeconomic status were at increased risk for inadequate self-care, practice education, insufficient breast cancer survivorship support, and low accessibility to treatment resources. And even though the mechanism driving the increased risk amongst minority patient populations is unknown, active prevention and multidisciplinary interventions are really imperative to lower breast cancer related lymphedema rates in this group. And we want to empower our breast cancer survivors, and we want to strengthen their self-efficacy. So one of the final projects I want to discuss today is a project from the cohort here at the Yale Cancer Center. So Stav Brown is our research associate this year, and Alina Chen is a medical student at Yale that worked on this. We wanted to look at whether or not we could predict cancer-related lymphedema. And interestingly, we have a huge cohort of lymphedema patients here. We have about 15,666 cases of axillary lymph node dissection here. So we wanted to look at outcomes. So we know that lymphedema is irreversible and incurable. There are over 38 prediction models available out there. So that's a lot of models. So what is wrong with them and why don't they work? How can we not predict who's going to have lymphedema? The limitations of the current prediction models are that they don't predict the time of diagnosis. They're based on small cohorts, and there's therefore lack of sufficient statistical power. Patients are followed for a very short period of time. They don't account for race and ethnicity. They don't even address important comorbidities. They don't include laboratory-based predictive markers, and they don't really give you the information that you need. That information is not readily available. So our aims were to look at the risk of lymphedema. Most specifically, can we predict lymphedema, but can we predict the time of lymphedema as well? So we wanted to look at the impact of demographic and clinical variables following axillary lymph node dissection. And we wanted to explore the effects of laboratory-based markers on the risk of developing cancer-related lymphedema following axillary lymph node dissection. And similarly, for the time of lymphedema, explore demographic and clinical variables and see whether or not laboratory-based markers can have an effect on lymphedema diagnosis. So this was a retrospective cohort. So we looked at all the patients who had undergone axillary lymph node dissection at Yale Cancer Center between 2013 and 2024. We collected age, BMI, gender, race, chemotherapy, radiation, diabetes, hemoglobin A1C, and then looked at outcomes such as lymphedema development and also time from axillary lymph node to lymphedema development. We did two multivariate regression models were developed to evaluate these risk factors specifically and at the time of first diagnosis following axillary lymph node dissection. We did a multivariate logistic regression for the risk of lymphedema and a multilinear and Cox proportional hazard regression for time to first diagnosis. So as mentioned, these were 15,666 cases. So when we look at other tertiary cancer centers, this is about 2 to 3 times the volume in only about a decade. So there's about 2345 patients, so about 15% of patients that developed cancer-related lymphedema post-axillary lymph node dissection, and that fits well with the literature. Patients developed lymphedema with an average onset of 20 and a half months post-axillary lymph node dissection. When we looked at the risk of lymphedema and particularly risk factors, so the risk factors that are associated are BMI of over 30, chemotherapy, which is not seen in other literature, diabetes, race, Black African American, as well as radiation. So those have all presented as risk factors in our clinical model. When we look at time to lymphedema, so race such as Black African American, Asians, and radiation are early predictors in terms of timing, so more likely early for them to present, and diabetes is a late predictor of lymphedema. When we looked at laboratory-based features in our model, so BMI, chemotherapy, and hemoglobin A1C at the time of axillary lymph node dissection. So this is also in patients who don't necessarily have diabetes, but it's rather that laboratory value. They were shown to be risk factors for lymphedema. And when we looked at timing, BMI of over 30 and hemoglobin A1C were predictors of developing late lymphedema. So the conclusions from this part of the study, this is the largest single center study. So there's no one else who has this much data. We're actually surprised at the amount of data that we have here, which is great because this allows us to develop this tool. So we can basically potentially predict and we can develop algorithms for individualized risk and time to diagnosis. This is the first study to highlight hemoglobin A1C as a novel independent predictive marker. These findings really offer a foundation to create these individualized screening tools and early preventive measurements in high-risk patients. And if you look here in terms of future studies, our goal is to really improve a multidisciplinary approach to treatment, to enhance early diagnosis, to prevent barriers and disparities in care, to identify novel biomarkers, to establish predictive techniques as standard of care, and to create individualized predictive models. And each of these can be its own massive projects and have multiple sub-themes. And I also want to put a pitch in there, as Kate asked me to do, that we do currently have a pathway as well for a breast cancer-related lymphedema in terms of how do we assess these patients. So I want to thank you all for listening, and I'm open to any questions. I'm looking at the chat. Okay, here we go. Yes, sorry, go ahead. Yeah, so that's a good question. So we don't think it's related to gender. And when we looked at our clinical model, we did not identify that. However, having said that, if we look at our cohort, it's mainly breast cancer-related lymphedema, so you could understand that there's a bias towards female. And when we did our prospective studies, about 80% of our patients were female as well. But currently, there's no predilection or anything that would imply that women are more likely to develop lymphedema. Again, with age, we didn't find that there was a particular age, but we know that the earlier you're diagnosed, the more likely you're going to have a worse progression. So there's obviously some patients who are born with primary lymphedema, so whether they develop it when they're born versus as an adolescent or later on in life. And we know the longer that they have lymphedema, the more their lymphedema progresses. But for secondary lymphedema, it's not known to be associated with a particular age. Thank you.
Actually, yesterday I asked this question. She had and then lymphedema bypass. About a year and a half out, doing really well, has no signs of lymphedema. She said, "Am I in the clear?" And I said, "No,"
Yeah.
but I didn't have a great response to her as far
Yeah.
as kind of what.
Yeah, I
would be
think
her
next step.
Yeah.
So I think her next step is for her to continue to follow. So interestingly, I feel that right now we do immediate lymphatic reconstruction, but we don't necessarily follow them long term. And we know if you look at when do patients develop lymphedema, the average is about 20 and a half months after the axillary lymph node dissection. So she's really not necessarily in the clear. But regardless of that, we have to continue to follow them because we talked about things like not even signs, but rather like symptoms, right? If she's starting to feel any progression or any heaviness, she's someone that I would consider really maybe even putting in a garment and having her use other tools to further decrease her risk. But she's definitely not in the clear.
Because I think it's a common misconception that they have alerts, even if they've had a sentinel.
Yes. Yeah.
Meaning no IVs, no blood pressure cuffs. These poor women get stuff over and over again in their arm that has not had any axillary surgery. What are your thoughts on sentinel lymph biopsy versus axillary section and the ability to use that arm?
Yeah. So I think even for both, we know that a blood pressure cuff, we actually have studies. A blood pressure cuff and IV, it shouldn't increase the risk of lymphedema. However, if you look at the lymphedema modality and care, a big one centers on skin care. So if, for example, the IV is likely to cause you an infection or likely to cause you skin irritation, that makes you more at high risk of either an cellulitis of infection or even progression of your lymphedema, similar with a blood pressure cuff. I don't know if you notice, but sometimes in the operating room, we have blood pressure cuffs on patients and their arm kind of changes colors a little bit. And you're like, what's going on? So actually, there's been a lot of studies that show that blood pressure cuff doesn't increase the risk of lymphedema, but it's the fact that it could cause some irritation, some skin changes, and therefore potentially cause them cellulitis. Yeah, it could be a trigger.
way to
3D, that would be amazing. So lymphoscintigraphy I used to use quite a lot. I actually don't use it here. One, because I actually really haven't found anyone who could really do it for me. So I do our own ICG lymphangiography in the clinic and in the operating room. But to take a look at it 3D would be super interesting, because what we currently do is, it's actually quite extensive, is we try to map patients. Let's say we're doing an upper extremity. We try to map this way, and then rotate and take different pictures and record them. When ideally what you want to see is, what do all the channels look like? So if we can translate all those images that we're taking into something 3D, that would be amazing. And if you're interested in that, I would love to work on that with you. Yeah. Yes.
wonderful. Thank you.
Thank you.
I'm curious about your thoughts around chemotherapy as an independent
Mhm.
risk factor. Considering either in the acute phase, it being a proxy for steroid use to
Yes.
treat symptoms, and in the survivorship phase, it being a reflection of potential sarcopenia.
Mm-hmm.
What's your team?
Yeah. So one, we were surprised to see that, because that's not known in the literature either. So typically we know that radiation therapy is a risk factor, is an independent risk factor, but we found that chemotherapy was, which was interesting. I agree that we have to separate it from the steroid use, but also the steroid use could also have an effect on hemoglobin A1C, the sugar levels, etc. So we're still going to delve into that data a little bit more to see as to why. But it's really interesting what we are saying about the late effect of the sarcopenia. We haven't really looked at that. Hi. Yes. Yes. Mm-hmm. Right. So breast lymphedema is actually very difficult to diagnose. So when they present with a red breast, or a breast that kind of swells, or a breast that continues and progresses, I really try to sort of get to be honest, it takes me, I get a lot of the information from the history and with how they're presenting, because I do think it's a rare diagnosis. So first things that I try to make sure that it's not is recurrence. And sometimes we often forget that that is a reason for swelling and for them to look different. Also, we talk about inflammatory breast cancer, which can also present that way. However, having sort of seen a few patients, I realized that the reason why it's so difficult to diagnose is because it's hard to image as well. So we've currently developed a few ways to image it in the clinic by injecting, very similar to, you can use ICG by injecting around the nipple areola complex to take a look at what drains the breast into the axilla, right? That's one of the ways to find your lymph node, for example, your sentinel lymph node. So I started using that, and as well as injecting some of the quadrants. I noticed that it's also hard to differentiate from radiation-induced edema, right? So I think that's why it's such a difficult diagnosis. If they haven't had radiation, but they're still presenting with a heavy breast, with a lot of edema that doesn't get better. When they do a lot of massaging, it gets better. I think that's breast-related lymphedema, breast cancer but if they've had radiation and they're very early following their course, I don't think we can diagnose it as breast lymphedema. So I think it's a very rare diagnosis, and there's only a couple of other places where we're kind of looking at how do we map it? Is it an actual diagnosis? So yeah, it's very tricky. Yeah, I think it's a diagnosis of exclusion. That's sort of how I would define it right now. Any other questions? Let me see if there's something here. There's a question here. Is it feasible to collect lymphatic fluid at the time of surgery? If it is feasible, what is the range of volumes that can be collected? Thank you for that question. So when we did that prospective trial where we looked at skin biopsies, looking at RNA sequencing and immunohistochemistry, we collected skin, we collected fat, and we tried to collect lymphatic fluid. Collecting lymphatic fluid is actually excessively difficult. We tried to, use different pipettes, and it was actually very difficult. The range of volumes that are collected are very minimal. Maybe 1 ml would be the max, and I'm not sure that that's enough to do any sort of studies with that. The other way to potentially collect it, and this is in patients who are undergoing liposuction, is to collect it in the lipoaspirate, but then you'd have to be able to find a way to sort of divide the lipid portion of it to the lymphedema, to the lymphatic fluid portion of it. And I think that can also be very difficult, but that's potentially another way to do it.